My name is Muhumza Solomon. I work in the Division of Health Information here at Ministry of Health in Uganda. And today I'll be sharing our journey in implementing the electronic community health information system. Go to next, please. Yes, so at the start of our journey of implementing the community health information system, and that was towards the end of 2021, we came up with the country objective of implementing a digital job aid for community health workers with reporting as a passive process. When we did some baselines, it was very clear that community health workers spend a lot of time in compiling these reports, and at the end of the day, the reports are not accurate, and little time is spent on delivering the services which are needed in the country. So specifically, we are addressing the issues of governance, ensuring that we have an appropriate governance framework for implementation of the electronic community health information system. And some of the challenges were we had a lot of systems being implemented in the community, which were disease-specific, program-specific. So governance was an issue. Secondly, to have aggregate functionality, which was in different programs, as I just said, that we had different programs, different partners implementing, having that into a single government-owned digital tool. And lastly is to ensure interoperability. As a country, we've been suffering like other countries with the issue of a fragmented system, siloed systems. So been working and working hard to ensure that systems are integrated, but also to ensure that the electronic community health information system is able to speak to other systems as well. We move over to the next. And moving on to the next, our country's approach. Our country's approach has been to select two technologies to power our electronic community health information system. And one of the things I would like to mention very clearly in this meeting, Uganda's definition of a community health worker is different. We know at the moment we don't have a standardized definition in the world that this is what a community health worker is. But for us, that is what we call the village health teams. And these are people who are volunteers in our health system, and they live within the communities and they're able to offer these services. In total, we have a target of 140,000 of community health workers. And I know when I talk to other countries, the community health workers are facilitated or paid, but the numbers are always small. So looking at the numbers that we deal with, 140,000, our management was a bit skeptical about, whether a single technology would be able to support these numbers at scale. So we came up with two technologies to power this platform. But our intention is having all the data that is collected, integrated into a single backend core for purposes of analytics and visualization. At the end of the day, the user shouldn't tell what the difference is, whether it is the CHT or the OpenSRP. So in terms of the technologies we chose, of course, is the Community Health Toolkit, which I'll be going into details well implemented. We also are using the Open Smart Register platform, OpenSRP. We can move over to the next. And of course, ensuring that we link the system to other core systems we have in place, because at the moment we've linked it, we've been able to integrate with eCHIS too. So among the service areas, and specifically this is for the CHT version, because the OpenSRP based one is still under development. We just did user acceptance testing. So the service areas, we have maternal health, where we look at antenatal care, postnatal, we have family planning, for child, we have nutrition and ICCN plus, and the others that you can see. But also what is important to us and what has been very important to the government of Uganda is ensuring the monitoring of stock, because this is where we've not been so efficient, and yet we know that these commodities are needed for service delivery. So the issue of accountability has been very important to us, very critical to us, ensuring that there is accountability for all the commodities that we give out. But in terms of other features, we do have longitudinal person tracking profiles to ensure that we have patient-centered care embedded within our system. And I'll be going through the details, care decisions for decision, care guides for decision support. And as I've already mentioned, our VHTs, or what we call the village health teams, the cadre and the level of education is not as advanced as the health facility staff. So they definitely need guidance to be able to support their decision making. And also the application has some in-app dashboards, which the VHTs are able to look at and monitor some of the important indicators. We could move over to the next. So on the right side, of course, was a screen of how the system looks like. So again, looking at our structure within our systems, we see that at the bottom, as I've just mentioned to you, we have our VHTs who live at the community level. And as a country, we have around 140,000, just repeating. But then we have a VHT coordinator that lives at a parish level. And this VHT's coordinator in the previous paper-based system was to just go around collecting all these registers and aggregating these numbers, trying to put them together and verifying. But in the community health, the electronic version, they still play a critical role. So they are the ones who are champion users. They are able to mentor and support other VHTs. And then we move to the level of health facilities. So we have our village health teams attached to a health facility for purposes of supervision and service delivery. And we have a health center 3 who's in charge and is able to train, follow up, and mentor and supervise these VHTs. At a health facility, we also have a health assistant who's overall in charge of the health facility, of course, for purposes of supervision of all the services being offered. As a country, we also have a district level where we have the district's health technical team, or we call it DHT team, that looks at various issues which are coming up, the challenges, and how to overcome them. Then we have the MOH team, which gives technical guidance, strategic direction, and able to support the teams that are in the lower sections of the health system. Next. And we could move on to the next one. So that is a very interesting hierarchy and ensuring that we have support. So the update I'm going to give is concerns to the rollout of eCHIS that is based on the Community Health Toolkit. So as I mentioned, the one based on OpenSRP is still in the development stage. So you can look as a country over there, we have, we've so far reached 9 districts, and we've so far reached 2,111 VHTs. And you look at the total in those districts, you're supposed to reach is 23,000 VHTs. So we still have a lot of work to do. But look at, we just started in November 2021. So the 2,111 has been an effort that we're able to achieve the entire of last year. So a lot of work has been happening. We have development partners who have been supporting us. We have UNICEF, we have Rockefeller Foundation, we have UNCDF. Those are the ones who have come through. We have Global Fund, but we are still working out modalities of support. And what has also made, of course, a success for us to reach these numbers are the implementing partners that we have. So the orange one is BRAP, which is in Uganda, very well established, is in West Nile. We have Living Goods. I'm sure most of us are familiar with Living Goods supporting us. And what has been interesting, for example, for District of Oyam, is that we had Living Goods which had rolled out their own system called mHealth, and they've been able to transition these 209 VHTs from an organization custom system onto the Uganda official electronic community health information system. So that has been a very big landmark for us there, or milestone. And lastly, we have Malaria Consortium that has rolled out a district-wide implementation in Buyukwe. So that is That was in December last year. That was the first time for us to reach all the corners of the district and have all the VHTs. And it's now our model district going forward in terms of implementation. We have Amuru, which is 146 VHTs. This is the first district where the government of Uganda is rolling out on their own with minimal support of partners. And we're able to take on that district. That has been a very good learning for us. We'll move over to the next. And moving on next in our presentation, we see that in terms of, we have many times to make presentations, we kind of don't pull out the sample of, you know, what the indicators we're monitoring or the data that is coming through. And I thought this would be important to showcase in this presentation, because it tells a story of how we still have challenges with rolling out or implementing the electronic community health information system. So at the moment, you can see that the national level, I think, of March was 62%. Our target is always 60%, so we're a little bit above. But you see in the previous months of February, January, we're a bit down below the national target of 60%, and that always gives us sleepless nights. But when you move down to look at how the districts are performing, you can, for example, see the government supported district directly, you know, where we rolled out Amuru is not doing so well when it comes to reporting. And those are the things where we learn from as a government in terms of what model could work for us best in terms of implementing an electronic community health information system. And amidst scarce resources, when you see Amuru, it's because the government doesn't have these resources in place to reach there and do refresher trainings. Lamon Tungamo was UNICEF project, but the project ended. And when it ended, we see that the numbers are diving down. So we've been asking ourselves, would this be the best model? What is sustainable? So those are some of the questions which are going in our minds. Those are the discussions which are going to ensure that we have a sustainable system in place. We'll move over to the next. So that was just a sample to show you the efforts and some of the challenges. As I continue speaking to those challenges, you will understand from which point I come from. So besides reaching the 2,111 users, we've been able to establish a community health information system implementation coordination platform. Honestly, the members of this platform meet every week on Thursday mornings, and this has improved a lot. It has improved a lot in terms of implementation of the community health information system. We're able to receive support, and the partners now understand what exactly is required of them to support. And as we talk, we've garnered support to scale to 11,000 VHTs because of such platforms. And we have these resources lined up. I think in a few months, we shall be reaching more. We've successfully integrated with the electronic health information system, community health information system with the eCHIS. So for the district, Buyikwe and some to Lamon Tungamo, where we have the entire catchment digitized, they are reporting directly through the system of eCHIS. So those other districts are not using, you know, in aggregation. But initially, of course, there were challenges. We didn't roll out so well. In some districts like Nebi, Maracha, the other districts would digitize, you know, out of the catchment area, we're digitizing 30%, 20%, but that has been a lesson. Going forward, we're doing the 100% of the district. We've been able to develop a data observation toolkit that we call DOT. We know that quality data is important to make quality decisions. So it's very important for us. It's not about rolling out the electronic community health information system, but we are also, you know, worried about the quality of data that is coming through. And this specific tool is able to detect if there are duplications. Maybe they could be as a result of a system, you know, issue that we are getting duplicates, or the aggregations may not be proper. So this is a data science-based tool that was developed with support from Rockefeller Foundation and UNICEF under the eCHIS project that we are actually deploying live next week, and we shall be able to run some tests and see how best we can better utilize that tool. We've also drafted guidelines. We started out without guidelines and, some disorganized implementation, but at least now we are on a harmonized path and we're following these drafts until they're approved. And then our implementation will be well guided. We can move over to the next. We've been able to translate, of course, the application into a local language. There was a discussion whether this tool, if translated to a local language, would improve the understanding or comprehension of the tool. Could move over before, on challenges. So we developed this specific tool to be able to ensure that we are able to address the challenges. And of course, some of the challenges will continue talking. So some of the challenges we've faced is that one, the power supply and access. In some areas where we are deploying, there is intermittent power supply, and this would definitely force a VH to use their phone once the power is on. If it's off and they've run out of battery, roll back to paper. What we've done is actually make solar kits part of the package when we're rolling out to VHTs, so that if power is off in Uganda, in some rural areas, it can be off for a week. So if the power is off, then they can be able to use solar kits. We have issued the personnel or the VHTs that we use. I've already talked about the education level. There's poor comprehension of these workflows. So we have mandatory 3 refresher trainings immediately you deploy every month for them to better understand, but as well we've translated to Uganda to see a local language, to see whether these VHTs, best understand. And if they understand, Uganda has around 43 languages, which are so many, but we shall try to translate to more common languages where these VHTs are more comfortable to deliver services that are needed. There's of course a problem of poor network supply. That is one of our biggest, poor network coverage, sorry. It's one of our biggest problems. There are some areas which are a bit remote, but we are working with the telecom companies to ensure that there's good coverage, but as well, of course, the offline mode of the application really helps us, because the VHTs then move to spots where there is network coverage every time they want to synchronize. But I also need to talk about cost of internet. It is really a big hindrance to us and the limitation. And we talks with the network providers to see that this is zero rated, or they make access to this system free, and that is going to be one of the biggest game changers for us. We have a challenge of commodities. Commodities, I think, is always a challenge, but we are working with programs and we're making them appreciate the data which is coming through. And now the decision makers, for example, the PS, requires that we present to her every quarter the reports from this system, and she's able to track these commodities and task the officers responsible as to why there are no commodities in these places where they are needed. We have a problem of device management. Phones are lost. Some PHTs, they change districts, they move with their phones, and we've come up with device management guidelines on how best we can be able to solve that problem. I can move over to the next. So in terms of the lessons learned, of course, having governance structures in place is very key for us. Full ownership or proper engagement of stakeholders, as I've already mentioned, bring them on board is very key. For us, I've mentioned about zero rating. I've talked about providing solar kits and power banks. And move over to the next, please. And maybe among the last slides should be next steps. I've already talked about how we are going to scale up to 11,000 VHTs. How we're working on guidelines. Talked about the data observation toolkit and the translation. So that is done. I don't know if I can do my demo in the next 2 minutes. I've already pre-populated. I should be able to finish that within a few minutes.
Yes, you can.
So this is our tool that we've been able to customize. Of course, is based on the community health toolkit. And today we shall be looking at a certain household called Brian. Kakama's household had already pre-populated. So we shall, in that household, we have around 4 members, but in particular, we have a child below 5 years who is called Don Kakama, and we shall be doing an assessment for this specific child. So in terms of the assessment, I've already laid out that. We already have the date, and the date of birth is okay. So we shall just move over to the next. We have 4 danger signs, and one of them includes if the child is vomiting everything, which I've marked as yes. Does the child have convulsions? No. Is the child not able to breastfeed? And I put a yes. Is the child very sleepy and unconscious? This specific one is not. Does the child have cough? Mine doesn't have cough, but if it's a yes, then there are other options that you have to select. Does the child have diarrhea? Has had diarrhea for 1 day, and it's not bloody stool, or there's no blood in the stool. Does the child have fever? It's a yes. And we know these VHTs always have challenges. So this specific one doesn't have a thermometer. The fever has lasted 1 day, and they need to do an MRDT, but they don't still have an MRDT. So I put they are not done. And the reason is no stock of MRDTs. HIV or TB infection, fortunately, this one doesn't have any exposure. Does the child have any exposure to TB? I've also selected a no. Then we use MWAC tape to see if, to take the MWAC of the child, but this one is green and the child has no edema. So we know that as per our guidelines, we're supposed to give vitamin A twice a year. So we're in the first quarter of the year and we're just moving into the second one. So it is a yes, and the child has received vitamin A and they've received for the first dose. So this would be, of course, the result. This particular child has had diarrhea for 1 day, fever for 1 day. Remember, malaria, we didn't do an MRD test, and the danger signs are just 2 out of 4. And this specific child has been referred. And of course, we ask if differential treatment has been given. And for my case, it's a yes. And that is rectal artesunate. And the VHT was able to use 1 pair of gloves because we need to account for these commodities that we use. So that would be a summary, and that's how the VHT journey within a household interaction would look like. Of course, mine has been fast, but definitely as interact with the VHT is able to pass on some health communication messages to the household. So that has been my brief presentation. So over back to you, Anthony. Thank you so much.
All right. Thank you, Solomon, and thanks for the demo. So I will take this opportunity to give community members an opportunity to ask 1 or 2 questions before I also allow Solomon also to ask any question. Does anyone have a question? Feel free to come off mute and share your question. All right. So feel free, if you are not willing to talk, feel free to type your question in our call chat. Solomon, do you have any question that you'd like to ask in regards to the CHT product, or any question you'd like to share with the CHT community?
Yes. First of all, this may not be a question, but it's more of like a comment. I would like to thank the CHT community for having an amazing product in place, which is really helping shape and change lives in Uganda. But the other thing I'd like to ask, and at some point, of course, I've gotten some feedback. You know, when you look at the numbers, Uganda is looking at 140,000 users. I would like to ask, on a single instance, how many VHTs can we have? Is it 20,000? Is it 40,000? I think in the last meeting was around that figure, but I just want to confirm again. Otherwise, many thanks, and we appreciate the support.
All right, and thanks for that question. It's very timely. Mark, would you like to take that? Yeah, I'm not sure if...
Sorry, I'm having
Okay,
Zoom difficulties here. Can you hear me all right?
Yes, we can hear you going.
Yeah, and so I think it's probably a longer conversation about how to set up 140,000 users on a CHT instance. What we're seeing now, or make sure to do, is a more distributed backend. So on a single instance, single piece of hardware, we've been maximizing the number of users you can have on there, doing more work to increase that number. But ultimately, for that many users, it's unlikely to ever be on a single machine, a single box. And so we have ways to do that in a distributed way. So I suggest we have a follow-up conversation about that and look at how we could support that for Uganda. I'm trying to see who on the call here. If Derek is here.
We also have Diana. I'm not sure if you'd like to share your comments. Derek is not on the call.
Derek's not? Okay.
Yeah.
I think I approve with Mark's follow-up conversation.
All right. Thanks, Diana.
Yeah, so Anthony,
so
if you could connect us our follow-up conversation, it'd be great to have that soon.
All right. Yeah, we will be able to follow up with you on that, Solomon. And we also hopeful that after our discussion, we can be able to transition our findings and recommendations on the forum so that the whole community can be able to benefit from that. Thanks for that question.